Very good afternoon to all of you, and a warm welcome to the North of England HCC Educational Session. This is one of our first sessions on sickle and pain management, which plays a really big part for each one of us across the UK for looking after sickle patients. We've got none other than Dr. Sanne Lugthart. She is a haematology consultant at University of Bristol. She's also the honorary clinical lecturer at Bristol University. After completing a PhD at Erasmus University and Cornell Medical College, Sanne went on to complete her clinical training at the Erasmus University Centre in 2016. She is the network lead for the Southwest HCC, and she also is the SHT lead for Sickle at Bristol. Her main interests include hemoglobinopathy, lymphoma, and CAR-T therapy. And besides this, she's very actively involved in clinical research. She's a PI for several phase 2 and phase 3 trials. She sits in the hemoglobinopathy CRG, and she leads the National Sickle Pain Group, and she's part of the Sickle Pain Research Subgroup, which is in the process of developing clinical trials for acute pain in sickle cell disease. Thank you very much, Sanne, for being here today and giving us some update about all of this. Over to you. If everyone else can mute yourself, that would be great. Thank you.
Thank you, Nandini, for the kind introduction, and welcome everyone. I'm going to discuss the acute pain management in sickle cell disease and give you a brief update of our national pain group and also an example of our local pain services and how we've been kind of trying to turn things around for our patients locally. Please feel free to ask any questions throughout the meeting if needed. I'm happy to keep it interactive as well. I think this is really important. So I think probably this is the overview of my presentation today. I'm going to give a brief introduction about pain in sickle, then go into our national sickle pain group, what we have done in terms of work so far and what might be coming in the future. And then I'll share a local quality improvement project which we completed in Bristol in our own, also in my centre, using patient voice to improve things, and also what the important pitfalls can be when managing pain in sickle cell disease, and some brief take-home messages at the end. It's a big topic, so I hope I'll be able to get through everything today with you, but again, feel free to ask any questions. As you all know, acute pain in sickle cell is the hallmark. It's the major problem that patients present with to the emergency department or day unit, whatever service you have. We know that the annual numbers of a veno-occlusive crisis of patients globally is around 5 per year, so that's a huge number. US numbers are depicted here. 78% of patients who present to the ED have acute pain. In England, these numbers are slightly lower, about 50%. But what we do see, if you look at 10 years, so from 2001 to 2010, there's an increase of 50% of patients presenting with pain. So it remains a huge problem, and we're not tackling, you know, the origin of the crisis, to be honest. And the recurrent VOCs obviously impact organ systems, as you all know, and leads to an impaired quality of life and significant morbidity and mortality. So this is data that was published a long time ago in 2013, but it shows that the more frequent patients present to the ED or get admitted, the worst outcome they have, and that is seen here. So the black line is the line that includes patients that present one or more or get admitted once or more over the last year, and they do significantly worse than patients who do not present. So we should recognize that these patients therefore have a worse kind of phenotype of their disease. There have been long-standing challenges in managing acute pain in the NHS, and all of us are probably familiar with the APPG report, No One's Listening, that was published in November 21, that highlighted routine failure to comply to national standards, the NICE standards. I'll go into that in a bit. That there was significant variation in care between different hospitals and different units. There's a lack of joined up care between those different departments, even within the hospital. There's inadequate community care, and there is a lack of staff education and also attitudes of staff that require attention. So that's the current problem. What are the current guidelines? We have got the UK NICE guideline around acute pain management in sickle cell disease, which was, I think, initially published a while ago and then republished in 2016. But what it will tell you is that if a patient presents to a healthcare professional with acute pain, you have to provide pain relief within 30 minutes of presentation to the hospital. You have to reassess pain every 30 minutes thereafter until the pain is relieved or the patient is discharged. And thereafter assess the pain relatively frequently, and that is every 4 hours. And then there is a bit of contradiction that you also have to, if patients take an opioid, you have to assess them clinically every hour using blood pressure, respirate, saturation, and hazard ratio. The NICE guidance advised to consider a PCA pump if the pain is not controlled after a couple of hours. They do not advise pethidine to be used. Within the pain group, we have looked into whether there would be an update of the current NICE guidance. But my interpretation of things is that as the literature has not changed significantly, there will probably not come an update. Now, my personal view of the NICE guidelines is, and this is again my personal view, is that it doesn't actually include a lot of detail of what you should do on it in terms of protocols, in terms of pain management. And I think that's where there's a big gap, and hopefully we'll be able to fill that a bit with the work that we've done with the pain national pain group. So again, the acute pain should be treated within 30 minutes of arrival. And this is a schedule that's mentioned in the NICE guidelines, which we also have got in our local guidelines for nurses when they're on the day unit, to keep reminding people that we have given pain relief, but we have to reassess every 30 minutes, asking, how's it with the pain? Have you noticed any difference? Do you feel improvement? What's your pain score, etc.? And when the pain doesn't resolve, we should escalate it to a more senior level and also consider a PCA pump. So that's something that I took from that guideline. And when I started my job in Bristol 5 years ago, I was told that we did not have PCA pumps available. So I'll go into that a bit more later on. Again, but even when you get on top of the pain, then consider discharging the patient, it also should always include discharging the patient with some analgesia to take home. And I think there's also something where we can improve on. There are more guidelines. There's the American guidelines, which is published in 2020, and looking into that guidelines got a lot more detail. And this guideline covers acute as well as chronic pain. And what they've done is a panel of experts have done an extensive literature search and searching all the literature up to 2017 and just listed what those results were. Now, the Americans have a different timing. They identified rapid assessments within 1 hour and noticed that that's different from our current NICE guidelines, which is 30 minutes. And they want patients obviously to get the analgesia quickly. similar reassessments every 30 to 60 minutes. They promote mainly non-IV routes of administration. So then talking about subcut and intranasal to facilitate rapid analgesic treatment. They highlight the need for tailored opioid dosing, so using individualized care plans, and they do use ketamine in case patients have difficult to treat pain despite opioids, or you were not getting on top of pain quickly enough. Now, we've done a literature search on, novel pain medications. Is there anything new? And ketamine is one of the medications that have shown to reduce the amount of opioids in patients, whereas the outcome of the admissions or the duration of the painful crisis remains the same. So I think that's why, because the total opioid is reduced, I think that's why the Americans probably are slightly more a fan of ketamine. We don't use it in our hospital at all, unless I've got like specialist pain teams involved. So another thing that the ASH guidelines highlight is, besides the management of pain using medication, we should also focus on the non-pharmacological management of pain, and using, for example, TENS machines or virtual reality, or acupuncture, physiotherapy. That's something that in my experience sometimes is missed when patients are on the ward, and could for some be really helpful. A bit about the National Sickle Pain Group. So this group was actually formed on the recommendation of the CRG, and this was set up or initiated by, back then, Professor Joe Howard and Paul Telfer in April 21. So before the APPG report came out, we actually established this group. And we're fortunate to have a variety of different experts, but mainly adult and pediatric hematologists, clinical nurse specialists, pharmacists, some physiotherapists, but also chronic pain specialists, palliative care specialists, acute pain specialists, as well as a patient representative from the Sickle Cell Society and emergency department consultants. Initially, we lacked someone representing the ambulance, but we're now fortunate to have someone from the London Ambulance Service as well. So it's a different group of different specialties, but all having one thing in common. We all want to improve the pain management of sickle cell disease in England. And we asked ourselves the first question, like, what is the current practice in England? Back in 21, we obviously knew that some centres were meeting NICE criteria and others were not, but we didn't actually know what patients or what centres were using in terms of protocols. So we wanted to identify the practices nationally and identify the differences in what works well, where can we learn from, and how can we improve. And we also wanted to get more insight into the current protocols that centers use, the patient experience, and also what training and education staff were getting in order to improve. Now, this is a big chunk of work, and it requires different groups to work on the different angles and the different topics within pain. So what we have established is that we identified 4 big groups, and they've kind of become subgroups of the National Pain Group. And I've depicted all of them here. I've also highlighted in bold the persons leading those subgroups, because let's face it, it's so much work, we can't all do it ourselves, so we need a bit of help. Stella Kotsiopoulou is a consultant hematologist who's in charge of the acute pain group. We started the acute pain audit, the national audit, back in 21. We've developed an action plan for trust to respond to the APPG report. We have a template of an individualized pain plan and a nationally agreed pain audit. And our plan in the near future is to publish examples of good quality of care in different centres, and that's already kind of being delivered, for example, in some of the London centres, etc. Now, Asad Likmani is a consultant who's in charge of the chronic pain. We're at the brink of starting a national audit around chronic pain, again, slightly similar to acute pain, but highlighting which centres have got expertise in management of chronic pain, which is a different, sometimes a different group of patients. Guidance on frequent attenders or patients with complex pain, and also having patient voice groups where we ask patients what their view is of chronic pain, how do they see it, what do they want improved when managing their chronic pain. Professor Paul Telfer is leading the research subgroup, and we got funding to develop a clinical trial protocol for pain and management in sickle cell disease. And this project is about to end at the end of December, and we hope to get subsequent funding to develop this actual clinical trial, looking at different pathways in acute pain. Now, Perla has taken on the lead for the education subgroup, which have developed health inequalities e-learning. I'll show a quick print screen of the Health Education England e-learning that's available for all NHS employees. And we've actually implemented that in the trust for all members of staff to complete that training. We also want to standardize education and training a little bit more. And the idea is that we do that joining up with the educational NHP group, which I think is also now established. Yeah, next. So we conducted a national questionnaire. It's not actually an audit, but a national questionnaire around acute pain in sickle cell disease, where we had multiple questions. I don't know if you remember it, but I think it was in 2021 over the summer, and we asked all centres to complete. And I think your centre completed this as well as some regional ones, or the one in your network. So nationally, 39 centres completed the audit, and we separated the pediatric and the adult services. So in total, we have 56 departments who responded. So quite a huge variety. And when we looked at what these centres were, half of them were actually local hemoglobinopathy teams, so the LHTs. There were different variety with a large range of patient numbers, varying from no patients to up to 800 per service. And there was an equal distribution between the adult and the pediatric services. Oh, wait. Yeah, sorry. Half of the centers were using the emergency department to manage patients with acute pain initially. So that's depicted on this slide. There were also centers combining the ED or the ward or ED and day unit, but the majority of them still have the emergency department as first point of call for patients when they present with pain. And that was actually that I found an interesting observation. And our plan is to re-audit this next year to see if there's a difference. We asked centers about individualized pain protocols, and the majority of them did manage patients using individualized pain protocols. Most of them had a generic pain protocol available in addition as well. So that was about 90%. But 61% of the centers used individualized pain protocol, and about 71 only did that for selected patients and 29 for all. So Things that were used very frequently was morphine and oxycodone. And most commonly, these were oral or subcut boluses, and in some centers, PCAs were used. We identified that in the pediatric services, PCAs was used more frequently, and there are some centers also using intranasal. And that's not used everywhere, but we did highlight that that was indeed something different. The availability of ambulatory care or day units was very limited. At that time, only 14 centers, so 25% in total, had an ambulatory care service available where patients were able to come when in pain. Now, the availability of these services were variable between 5 and 7 days, and at that time, 8 a.m. between 5 p.m. So actually normal working hours, meaning that after that, they probably go to the ED. Again, this might change in the future, but the access was also limited by having access for all patients, or patient had to pre-book. In some centers, they had a protocol kind of version of how to triage patients so that they did not have any red flags. And other centers only allowed patients that were known to their service. When we looked at the time management and how quickly were they able to, or how, what's that 30 percentage of 30 minutes to first analgesia, which is a nice requirement. About 50% of those centers with an ambulatory care service were able to meet that 30-minute criteria. Now, when we looked at the centers that did not have an ambulatory service or a day unit available, only 21% met the NICE criteria, with averages around 30 to 60 minutes and outliers up to 80 minutes. Pediatrics in general was a little bit lower, 20 to 60 minutes time to first analgesia, with outliers of 128. We looked at the average length of stay, and reassuringly, that was quite similar across all centers, between 3 and 5 days. The same for patients who were admitted for very long. I think each center had a couple of patients that when they do come in, they are admitted for quite a long time, and that was between 0 and 5%. And 2 to 10% of patients had frequent readmissions. And the definition of a readmission is when you are admitted more than 3 times a year. Again, it was reassuring for us to see that these percentages were similar across all centers. So there was no kind of outlier there. In terms of training, it was quite variable, and I've highlighted ED consultants, ED nurses, and acute medical or pediatric consultants. We're not getting frequent training. You should ask yourself the question whether yearly training is enough to know something about sickle or to know about pain management. So I don't think that is the case, and you should have at least 6 monthly or even more frequently, depending on your patient load. A lot of responders, a lot of people who completed audit were willing to share training and give examples of that. So in conclusion, this national audit shed a lot of light in terms of management from different centers. The majority of the patients are still managed in the ED department, and unfortunately, the time to first analgesia is often delayed. Protocols of pain management in sickle cell disease show a large variation across centers, and centers with an ambulatory care service have reduced time to first analgesia. Education and training is lacked and given very infrequently. And I didn't mention this earlier, but only few centers were having patient satisfaction questionnaires. And I think that was also a gap we highlighted, is that it's important to involve your patient in that, and therefore you need to ask them how they are experiencing your service. We then as part of the research group, we organized a national sickle pathway or sickle care conference in May. Now, I'm happy to share the slides with you all because I've put in a link to that meeting, because the whole meeting was recorded. So if you ever have time to look at it, please do. And the good thing is you can fast forward. So it was a very useful meeting, simply because we got several trusts to present their audit data, their time to first analgesia, and how they manage patients and in different settings, from emergency department at King's, for example, to a day unit as presented by Professor Mark Layton. So that was really insightful. And we picked kind of a couple of ideas that we are going to hopefully implement in our trust as well. So I do recommend everyone just to have a quick look at that conference. We also had experts from the United States presenting their experience on how to improve time to first analgesia, and Sophie Lanscrom did that for kind of infusion centers, which are similar to our day unit. And Paula Tunabi presented how to tackle the problems in the emergency department. And she has developed an excellent toolbox, which is available online as well, which you can again go to use for your center if that, if you're struggling with the ED. We also had, I think, NHS England or commissioning present about the new sickle cell pathways, including the ideas or the new implementation of the hyperacute units and the digital care pilot. So what we notice is that there's so much happening and different groups doing different things that we kind of wanted to connect all these dots in the meeting to just share with everyone what is going on and what is coming. Patient feedback on the experience when they have a VOC, it remained really poor. We invited patients that day, and it was really useful to get their first-hand experience. They recognize that slight improvements have been made, but it remains important to hear their voice. And again, the link to the day. Let me go to the next slide. So this is just a little kind of information of what we have achieved so far with the National Pain Group. And I've listed here some other things that we want to do going forward. As I said, the Acute Pain Group is now focusing on kind of publishing local examples of excellent care. We are planning to re-audit our initial audit in 2024. We're hopefully sending out another questionnaire for chronic pain, which the chronic pain group will then get more information of. And we want to identify centers with pain programs and their outcomes. We've invited a couple centers already over who gave some really insightful information, and there are some centers offering chronic pain clinics in parallel. You have the sickle consultant there, and then you have a chronic pain consultant. So having both experts in one clinic can be very good. And then with the education bit, we're planning, the idea is that we link up with the NHP education group to see if we can standardize things a bit more. I think we're now really fortunate to have all these education sessions available and everything, but we need actually one place to put it all so we can find it easily and look back. The idea is to also connect to colleges. I mean, it's about the nursing staff and our doctors and the pharmacists to learn about sickle and pain up front rather than, when you're already in the hospital. Oh, sorry, I'm going too quickly. The research group is planning to hopefully get more funding for the clinical trial. And we are thinking about comparing the emergency department with the day unit and see if there's a significant difference between the two, or whether it's just about training your staff that will make the difference in terms of time to first analgesia and patient experience. Okay. that was the National Sickle Pain Group update. I'm now gonna go to the Bristol part of my talk. And as you can see here, this is the Bristol Clifton Suspension Bridge, and I put this picture on because it's got a bit of dark clouds above. And I'll just take you to a bit of our journey in Bristol. When I started my job in 2018, I came into the hospital new to the NHS, and as Nandini said, trained in Holland. I had seen many sickle cell patients in Rotterdam and had a clear idea of kind of what we were doing until I came here. And then I just I noticed that we are managing patients slightly different compared to what I was used to. And one of the things that was slightly different is that there was no pain team involved in pain management of sickle patients. And so the hematologists were on the ward were seen as the expert of the pain that sickle cell patient had, because the sickle cell disease is a hematological disorder, therefore managed by hematology consultants, and they should also deal with the pain. Whereas I came from a school where the anaesthetists in the pain team were seeing our sickle patients, and they had already managed to get on top of the pain before we even see the patient. So in Bristol, we've asked the patients, okay, what do you try at home? What are your pain scores? We would give them NSAID and paracetamol, and this is kind of a copy of our local protocol that we had. We said consider PCA when you don't get on top of the pain, and do that after 1 or 2 hours, because we do not want that patient to be in pain for hours, because the idea is that the crisis will just continue, and then the patient will be admitted for a long time. We initially used diamorphine, but we switched to morphine last year simply because it's more widely available, and I think it's just more an easier medication to use with less side effects. Diamorphine can give some more side effects. So for opiate naive patients, we give a specific dose subcut, and we give that every 30 minutes. For the non-opiate naive, it is a little bit higher, and also give it every 30 minutes, etc. Now, I've tried when I thought a patient is in pain and we're giving a subcut injection to a patient in pain to get on top of the pain. A subcut injection is not very comfortable to get. And I thought, giving someone subcut injections for pain, is that the right thing to do? So I then asked, my pain team, who then said, oh, we don't really do PCA pumps, and therefore, that is not available for your trust. So I then went back to my team and said, okay, let's do a quality improvement project around pain management in our hospital, because I'm not sure what's happening. Let's first identify how big is the problem. So we done an audit of our last 20 or 21 admissions, and looked at, are we meeting the 30 minutes time to first analgesia? And we didn't. Only 58% of patients will get their pain relief in time. And this was before we had our day unit open for 24 hours. So the data have now slightly changed, but it wasn't what I expected, and it wasn't good. So we went to the patients, and these 21 patients that we knew that only half of them we have given pain relief on time, and we asked them what their experience was, and we asked them several questions. And we said, okay, we would normally give you the pain relief within 30 minutes of arrival. In your view, in your experience, when you were there with us, did we achieve that? And then 3 patients said no, and 2 said, yeah, maybe to some extent. So it was confirmed by the patient that no, we did not meet the criteria. And this is some of the things that they gave us, like, in the free textbooks, text boxes. What information did they give? These are statements. It feels like, sometimes felt like they had no record of me, so that they had to start from scratch. I don't know. We very rarely get the first dose in 30 minutes. Maybe it's because of the of COVID. I'm in a side ward, and then other statements were, well, to some extent, but the pain relief was wearing off really quickly. 45 minutes. That's quite a long time. Did you feel that there were any times that you had to ask for more than once for pain relief? A majority of patients said yes. When I was initially admitted, that's how I know I was not within 30 minutes of arrival. I would take a long time for the bell to be answered. Oh, sorry. It was a pain that the pain relief was not offered. Oh, it was a pain that the pain relief was not offer for the time being. So I think it tells us that they get increasingly more frustrated. No, they don't get the pain within 30 minutes, and then we're not getting on top of the pain. We're not answering bells. We're not there. Okay. Is there anything you would like to see change regarding pain management? This is what the patient came back with. Please put some consistency between the patient and the nursing team. Having to repeatedly explain and justify oneself in order to receive pain relief is unacceptable. No, not really, just a little bit of increased pain relief for the time being, and we did have some positive feedback. What you're suggesting on this form is perfect. So again, it's really kind of a mirror to see what patients come back with, and clearly we were not doing it the right way. So what did you feel that worked well and during your admission? We noticed that when in the patients where we did it well, there was a team. We got we got on top of the pain quickly using the right dose of opioids and using the right assessment. That means frequently ask how they're doing, do you need more, etc. So this is their feedback. Being given the right dose of pain relief. The dose was right, so my pain became under control. So I got discharged soon. This is again all the patients telling us. Once pain relief was eventually administered, I became much more settled and knowing that I was in safe hands. The quicker the pain is arrested, the quicker I feel my recovery will be. So yes, right time and right assessment was a theme that we picked up from this. So we went back to the wards and identified areas to improve. So for the right time, what do we want to improve? Well, there were several patients complaining about the bell, calling the bell call on the ward. We implemented pain observation sheets for nursing staff to just keep reminding them of, and also the doctors to assess after 30 minutes. Yeah. The other thing we did is that underneath all of these patient feedback is that we want to address unconscious bias with staff. It might be that because we don't see the pain with the patient, the nurse might think, okay, well, the patient is all right. He's lying in bed flat and just probably sleeping, so he's not in pain. So this is unconscious bias, which we need to be aware of because that can influence how we deliver our care on the ward or in the day unit. The right dose. We're underdosing sometimes because junior doctors or staff that is not familiar with these protocols is very anxious about possible complications, which is completely understandable. But as long as we make it clear that this schedule, this individualized pain plan was made with the consultant and with the patient agreeing to it, we should be able to deliver that full dose and we should not underdose these patients. Sometimes it was highlighted that the pain plans that we put in place were actually nowhere to be found. The staff didn't know where to find them in the digital notes. And there was a lot of difficulties accessing the record. And what we also identified is that there was, in some patients, we did observe toxicity. And that's just showing that that patient has a very narrow therapeutic window. And that comes back to the fact that that's what I've been kind of, telling, trying to kind of prove from the start, is that in some patients, you can't get it right, or it is very difficult to get it right. But therefore, you would need an expert pain team to get involved, because we're not trained to do all this. I'm not a trained pain specialist. I'm just a hematologist looking after patients with sickle cell disease. So I think working together with an acute pain team will change things. We managed to set up a checklist, a brief checklist for our ambulatory care service, for an emergency department, SHO teaching, nurse teaching. We made the individualized pain plan easy, accessible. And again, we identified unconscious bias, and we provided several teaching sessions around that for our staff in the whole hospital, so not only limited to hematology. And we got the acute pain team involved, which, again, we were only able to do that using the patient feedback, because I think that's when managers and other people woke up, because that was just really something that we didn't have before, and was very helpful for our service to get managers around the table. Okay. A bit about unconscious bias. I've mentioned it before, but it is actually proven that it lowers the quality of care, and it needs addressing among staff. There are several publications that have shown that healthcare professions can have some resistance to care for people with sickle cell disease, and that's multifactorial. That's due to the disease stigma, it's due to the lack of knowledge, it's due to the comfort of treating patients with sickle cell disease, or it can be an institutional or provider bias, or just simply racism. It leads to a more suspicion from the care providers, and patients will notice that, and it will lead to a lower quality of care. But what it will eventually lead to is that patients will avoid seeking care when in pain. And I think that happens quite frequently. And it's not until you talk to your patient that you'll find out that that's what's happening. They will simply tell you, I will not come to the hospital because the last time I was there, this happened. And when you have that, that's a big alarm bell. You have to look into your team and see where are my gaps and how can we improve. And also, I think eh, the experience on using different pain medication is slightly difficult, and depending on your individual training. But I don't believe that there's a one opioid or one combination of medication that does the trick, and that's a one, it's not a quick fix or one fix for all. So again, that's, I think, important to discuss with the patient what they've used before, and how are we going to how are we going to manage the first couple of hours when they come in with pain. Something we did is we, for example, are seeing everyone, or we call each patient after they had an admission with acute VOC, and we ask them, how was it? How was your admission? How was the initial presentation? When your individual pain plan was used when you were in pain, how did it work for you? Did it work well? Did it not work well? Why did it not work well? So each time someone is in the hospital, we double check at the end of their or before, when they're discharged a week after, we check, how was it? Simply to see, have we got anything that we missed? Is there anything that needs changing in that individualized pain plan? Now, I appreciate that you can't do that for all your patients, depending on how big your center is, but it is a way of kind of tackling the problems early on. Again, what do we do to improve unconscious bias? The answer to everything is always education. In this case, open door, it's education. However, we do need more treatments to tackle sickle cell disease in general, because if we tackle the problem, then patients will come in less frequently with pain. Unfortunately, there is limited treatment options available, so that's not something we can change very rapidly. It is about provider to provider education, but also mentoring. I think the NHP and the HCC has given us so much to kind of tag into different centers and have all the education. So I really think that should stay and is really important to keep on going. But sometimes we also have to recognize that only the people who are interested in that specific education will attend, whereas you need to reach out also to the ED and to your other wards that do not frequently see sickle cell patients to tell them about this. Improving access of quality of care. I mean, I believe the NHS has good access, so we should be able to do that right here. So again, a brief overview of what we improved locally to change, or hopefully to improve the experience of our patients. We've updated all guidelines. We have met up with our emergency department several times to dedicated teaching sessions, increased awareness by talking about unconscious bias, using the trust communication, and also delivering training. And we have also got a training session available for all staff on our digital kind of training platform. Our pharmacist is very dedicated, and we're very happy to have her. She dedicates some of her time to develop these individualized pain plans, and that's very helpful for our patients. We have monthly patient support meetings where we listen in about what's going on, what their feedback is, etc. And we've appointed a patient support worker who is calling patients after they have been discharged, in working together with our clinical nurse specialist team on that as well. And we've got acute pain team involvement. Now, that was a very difficult one to tackle, but we're now in the process of getting PCAs up and running on our department, which will be solely managed by the pain team, and there'll always be an anaesthetist available to manage patients who can't be managed with their initial pain plan. And then need to be escalated to the anaesthetist for possible PCA pump. So I think that's really important, but it took a very long time, 3 years in total, before we were able to kind of change this. This is some of our guidelines, just a kind of snapshot of it. You probably have them all yourself as well. I'm happy to share. And this is one of the individualized sickle pain plans that we conducted, or that we kind of agreed with the national team on. Again, it's very general in terms of morphine dosage. They're listed down at the bottom. That again can differ per center, but I would like to hopefully agree on something general for all centers nationally as a kind of go-to for centers who do not see many patients themselves. So my overall goal with this is to get something published for those centers. This is something that that we worked on as well. So Health Education England has got a health inequalities teaching session in sickle cell disease available. So you can look this up. This is on the e-learning for healthcare professionals health education website. And this is in the format that your trust can already literally copy paste this for your staff to train. So we've got this implemented for all staff in Bristol. And I know several other centers have done the same. So it's basically a copy paste, but obviously it requires one of you to kind of inform your trust about, can we please add this teaching session to our, to our start, for all our starting staff to at least have seen this. conclusion from the chronic or from the local quality improvement that I share with you is that the self-assessments using the audits are actually the best way to identify gaps in your care. Patient interviews are so insightful, and they made you prioritize your aim. Because, you know, we think sometimes things are a problem, but patients do not always agree, and the other way around. So patients are definitely able to highlight issues. And in our case, this training of staff had therefore made a priority within the trust, because there the patient's feedback was that's the main problem. Real-time feedback, as I said, after an admission, to keep on identifying new gaps and problems. The acute pain team, so specialist pain team involvement, took a long time, but I hope that it will be worth the difference. And it mainly took a long time due to the fact there's different divisions within my hospital. And it wasn't until I then contacted the chief exec to say, look, this is just madness, that it got attention. It took a long time. Re-auditing of our servers shows that we're not there yet. We're not meeting all the, unfortunately, time to first analgesia. So you know, it's quite, we're not, I think you will never meet 100% probably, but I'm hoping that as we get on, we continue to improve. So I hope that the line will keep going up, up, up. But I have to be honest, we're definitely not there yet. So we were in the 70s the last time we audited, so not meeting the 100% yet. In terms of continuous challenges, this is something you also probably deal with, is a high staff turnover, which means that you've educated your staff, and then the next month there's a lot of new people starting again. This has led us to create a new post, which is an education facilitator for specifically acute pain and sickle. And this is a dedicated band 6 nurse that dedicates 1 day of her time a week to train all staff. And that's a big job. She's a very important person in my department at the moment. There's day unit capacity limitation. So our day unit is now open 24 hours, 7 days a week. But if the beds or the chairs are full, patients are still left to go to the ED. So it doesn't always work well. It works well about 70% of the time, but the 30% is when the day unit is at capacity. It is unfortunate that we have to send our patient to the emergency department. The other thing is that we didn't even started working on, but we are now getting more in touch with our ambulance services, is that they do not always know that our day unit or our SDEC is available 24/7. So sometimes they just drop the patient at the emergency department, etc. So I think the ambulance services is a separate piece of work, which we only starting kind of now. But it's really good that we've got some national people from the ambulance service as well to kind of arrange things higher up, so also for ambulance services everywhere else in the country. Really, really brief take-home messages. Pain management for sickle remains a priority. Annual audits, you need to do them. They're harsh, but that's the only way to improve your care. And sharing experience and practice will help other centers as well. So I'm a big fan of just sharing what we've done and then take it from there. Patient involvement remains crucial, and sometimes we forget about the patients, but they are the ones that are experiencing this and they go through it. So we need to know from them what to get better and where the priorities are. I want to thank all my team in Bristol, as mentioned here. I've not listed everyone from the National Sickle Pain Group, but there's a big group of people not listed on here, but I appreciate everyone's feedback and all the help that they've provided. I could not have done this all on my own. So this is really the work of the whole team that I'm showing you today. And I'll stop sharing. Thank you for your attention. And look, the sky is blue with balloons.
Sanne, thank you so much. What an amazing session. I think you've done so much in the short time you formed, or your
Yeah,
team have formed a national group. I think
yeah,
that that's, it kind of really highlights how much of work we've got to do. And, we've got so much to learn from pain management in sickle.
yeah.
I'm going to open the floor for questions. There's a question on the chat. I think they've asked about use of diamorphine, about intranasal diamorphine of fentanyl in ED. Any comments on practice?
Yeah, I think Paul Telfer published that in children using intranasal morphine, that it was, or fentanyl, that it was safe to use, and that patient, obviously it's a quick thing to give. So yes, I'm very positive about that. Now, I think what centers are struggling with is that you can't always get this through your individual trust. And that's a different can of worms. Unfortunately, I think that really depends on your trust and your pharmacy. And unfortunately, sometimes you are very restricted in what you can get available. And there's not a lot we can do about that, but at least that I'm aware of that we can do. But I would say that it is important to highlight, if centers use it, what their experience is, and how, if it's positive, we need to probably get numbers and publish it, because I think that's the only way forward. If you publish that, the outcome is good, that that you're meeting your 30-minute analgesia target and you discharge patients, for example, then I think that's very, very good. But yeah, that's what I've got in terms of intranasal. So use it if you have it available, and let us know about it, because we're happy to collate
Yeah.
numbers, etc. Happy to help.
So the other, I was going to raise just a question on one of the things I find sometimes centers or units do is they draw 10 milligram of morphine and then they give 2 milligrams every 2 minutes instead of the actual bolus.
No,
So that
no,
what
you have to
point
give
one,
it all
yeah,
at once. You have to give
yeah,
it all at once. It will not work. So the pharmacology doesn't make sense if you give it every 2 minutes, or every that's almost like copying a PCA, but then you have to give a PCA. I think giving a bolus is not a bad thing. Yeah. So if you're worried about side effects, if you calculate the morphine dose on the basis of weight, you're on the safe side.
yeah,
Now, because you already automatically will lower your morphine for opiate naive patients. Now, if you give the 10 milligram, that's just the start, right? You give the
yeah,
10 milligram and then you assess, because if you then observe toxicity, you just wait a little longer and you just see how the patient is doing. Because most of the time when toxicity occurs, patient will tell us, they say the pain was under control, and then the doctor started worrying. The doctor was worrying about my respirate, was worried about blah 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 blah, but the patient tells you it's under control. So now the worst thing, it's obviously patient safety is first, right? So whenever you have to give naloxone, you have to give it. But from a patient perspective, it's the worst thing you can do. So sometimes, and that's why having these pain specialists around the corner is so important, because what they do is they just wait. And sometimes that's the
yeah.
best thing to do.
Yeah. So the first dose you'd give and then you
Yeah,
reassess. And I think I completely sort of I think that's a sort of take home message for
yeah,
for
yeah,
units who are
yeah.
sometimes a bit anxious, but
Yeah.
having the pain team involved will probably really help with some of that aspects. Yeah.
And
There's a,
also having the patient experience, the
yeah.
patients might have had those doses of morphine before. and responded well to it. So you don't have to be anxious then for side effects.
Yeah. So then there's a question, does the PCA protocol you develop with acute pain use subcut route? Is there a time limit on how long the patient can remain on a PCA?
We're currently developing a PCA protocol, but we will use IV. There are centers who use subcut, and we used to use subcut, but that was in my
Sorry, you just.
Sanne, I think you're muted.
sorry. So we're in development of the so we're developing the protocol as we speak. It will be IV PCA, and it's up to the pain team, like how frequently they will allow kind of breakthroughs. But there will be probably no background, because that's an whole other thing. However, what is important with PCA, if you give it IV, it will work probably better. When you use subcut, there is a delay of when you do it. So my previous, the person who was in my previous post used subcut morphine for our patients, and that was done together with palliative care. Now there we saw slightly more toxicity, and also it takes a bit longer for patients to get on top of the pain. So that's slightly, I would say, difficult. There is actually no right or wrong in this, other than assessing the patients, looking for toxicity, but more equally finding out how they responded and whether it will tip off the pain to a level that they can then accept. There is no limitation how long you are going to continue the PCA pump. In general, I would say if the patient is stable and if the patient is oral, you will switch. There's no timeline to that. That might be sometimes, unfortunately, it will be a bit longer. But then you have to talk to the patient to say, look, is there a chronic pain element? What is going on? But there's no such thing as, it's not surgery where you say, oh, you only use a PCA for 72 hours and then you stop. No, this is sickle. This is different. So it means some patients need 2 days and some need 3 or 4. But you always, every time, have to assess, okay, can we switch to oral? Can we switch to oral? And then you have to do that probably twice a day. And that's why having the acute pain team talk from a pain perspective with the patient could be better. Maybe in 5 years I'll tell you a complete different story, but I hope that's what helps. Whereas before, with our subcut PCAs, sometimes people the staff who see the patient every day, they almost forget that the PCA is on. They don't really see it other than the nurses. So it is really important to try to, I agree, we should try to limit the amount of time on PCA. If you just deliver the pain relief using tablets, you're better off, because it means that patient can be sent home with a couple of days of weaning the opioids off when they go home, to almost no, to no no pain relief. So yeah, that's I think what I would say about this.
Yeah, and I think it's quite, I know some centers do use subcut. It's very variable.
Yeah.
Some pain teams have very strong views against IV versus subcut. And I think discussing it with your local pain team or your acute pain team within your trust is probably going to be crucial for setting up this as first line, second line, what's feasible, what pharmacy can do. It's going to be really crucial. I think it's been a really amazing session. I'm just going to ask if anyone has any questions. No. Sanne, I think you've given an amazing overview, and thank you very much.